everyone. My name is Katie, and I'd like to welcome you to Evolving Landscapes and New Horizons in CFRD Management. I'm Katie, and I'm a 42-year-old CF adult. I was diagnosed at birth, but I'll tell you a little bit more about my story later on. I'll be moderating the session today, and I will be introducing our speakers in just a moment. I want to provide you with a few housekeeping items, but before I do, I need to remind you that this session is being recorded and will be available later on the CF Foundation YouTube channel. All attendees will be notified by email when the session recordings are available. We will be taking audience questions during this session, and we encourage you to submit your questions at any time into the question and answer box. Please know, however, that we won't be able to answer your questions about any individual treatment plans, but we encourage you to use the information that you learned today to take it back to your care team and to talk to your doctors about them individually. However, we will do our best to answer any of your questions as much as possible. If you experience any technology problems during your session, please visit the help desk on the left-hand side of your screen. We also want to remind everyone in our community to be kind, to be open-minded, and respectful of everyone's opinions. That is part of our community guidelines. Please do not ask, and please do not give medical advice. If you need staff support at any time or want to report a violation, we also encourage you to visit our help desk. So like I said, my name is Katie Oskin, and I am an adult CF patient. I am 42 years old. Little things about me that you might want to know. I met my husband in seminary, and we are ordained American Baptist ministers, and we serve in a church right outside of Youngstown, Ohio. Right now, I'm currently sitting in my home studio and office where I have a small little side hustle where I sculpt and make homemade sculptures. You'll see in a moment my childhood pediatrician, but I was taught a very valuable lesson at a young age that I am a person with CF, not a CF person. This enabled me to see and to live a life as if I was normal. In a world prior to modulators, this was a valuable life lesson. So you'll see a little collage of pictures of me. The top half of that collage is all monumentous graduations in my life, from NICU to high school to college, and even my master's, getting my MDiv. The bottom half of that collage is just fun stuff I did in life, from standing in four corners of the USA with my family, to visiting Germany to be with the other half of my family, to being the drum major in my high school marching band for 2 years, and getting married. And on the right side, me and my husband doing what we do the best and what we do for a living, being ministers in Youngstown, Ohio. Now I want to tell you something else. I was diagnosed about CF at birth, but I was diagnosed with CFRD at just 12 years of age. I consider myself to be a healthy CF adult, but I work hard to keep myself that way, just like many other CF adults do. This slide in particular represents 4 of the doctors that spoke life and breath into me from childhood, the black and white picture on the far side of the screen, Dr. Francois again, into my adulthood, the top picture and the bottom picture, my current doctor today. I want you to remember that your doctors are more than doctors. They are people too. And it's important for us to remember that as they breathe words of life, sometimes comfort and peace, and good medicine into you, they are people too, with good days and bad days. And sometimes they need comfort and care as well. It is with their help and their encouragement that I have found that I have had to use every single form of insulin ever available. From the time I was a child, drawing up insulin from bottles as an elementary school child, having to go to the nurse's office, to insulin pens, praise the Lord, when those became available. It was like a miracle sent from heaven. And even to today, an insulin pump. the Omnipod, which we will talk about later. Tonight, we are going to help to inform you about CFRD, and I hope and pray that you will learn something from each of our presenters tonight. So tonight, our first presenter is Dr. Amir. And so Dr. Amir, I'm going to ask you, what is the prevalence of CFRD? And I hope that you can tell us what medications are available.
Katie, thank you so much for moderating this session and sharing your beautiful story and those beautiful pictures. Hello, everyone. My name is Amir Moheet. I'm an adult endocrinologist at University of Minnesota. And one of my fun facts that I want to share is my happy place in northern Minnesota. These pictures that you see is of a wonderful wilderness in northern Minnesota called Boundary Waters Canoe Area. And that's kind of I really look forward to my yearly trip. And these are some pictures that I'm sharing from last year. So as Katie had mentioned, I would just want to start off this session by giving you a little bit of a background about CF-related diabetes, and I'm going to call it CFRD going forward, and also sort of kind of highlight some of the changing landscape that we are seeing in terms of nutrition and CF-related diabetes or CFRD in this era of highly effective modulator therapy. So what you see right now on your screen is showing the common non-pulmonary or non-lung complications seen in people with CF. And as you can see, in the red line shows the prevalence of diabetes. On the x-axis is the age, and the y-axis is the prevalence. And as you see, prevalence goes up as people age, and it's once people go, in older people with CF, diabetes is the most common non-lung complication. Now, here's another way of looking at this prevalence. Here it is, the prevalence of CFRD is shown across different age groups. You can see the age groups on the x-axis, and as you can see, CFRD is uncommon, but can occur even in children, and prevalence goes up with aging. And when we get to adults with CF, more than 50% of adults have CFRD. And if you look at specifically in people who have more severe mutation, then the prevalence goes up to 80%. So it is an extremely common and sort of an expected complication of CF. So what causes CFRD? CFRD is thought to be a multifactorial disease, meaning that there are multiple factors which may contribute to development of this unique type of diabetes. As you may be well aware, pancreas is frequently affected in people with CF, and pancreas has two important functions. One is where it makes enzymes related to digestion, but it also has insulin-producing cells called iLet cells. So as the pancreas is affected, we could potentially lose some of those insulin-producing cells. And the remaining cells are impacted by the altered structure of the pancreas. So the blood supply or the nerve supply to these remaining cells is altered so that these cells are not as effective, and that affects their insulin-producing capability. There is some evolving and contradictory information about if CFTR defect itself may be also involved in the pathogenesis of CF-related diabetes. Studies have shown that inflammation may play a role, particularly inflammation in the insulin-producing cells. Other factors that may contribute, including certain gut hormones called incretin hormones that can help secrete insulin from our pancreas, and also people who have family history of type 2 diabetes may be at increased risk of developing CFRD. Other factors that may contribute include in conditions like acute infection, exacerbations, use of steroids, body's capability to utilize insulin is impacted, and our body becomes more insulin resistant during these acute illnesses. Similarly, we are seeing that the rates of overweight and obesity are increasing in people with CF, and that could also lead to development of insulin resistance. So all of these different factors eventually contribute to what we call insulin insufficiency, which means is that our body is not able to produce the adequate amount of insulin that's needed to keep the glucose in the normal range and subsequent development of CFRD. So what are the potential complications of CFRD? Now, CFRD is a unique type of diabetes and is different from type 1 or type 2, which are the more common types of diabetes. However, there are some risks or complications which are common between forms of diabetes, and there's some elements which are unique to CFRD. One of the unique elements of CFRD is that it is associated with decline in lung function and decline in nutritional status. So treating CFRD, particularly with insulin, is one of the unique aspects which have been shown to improve these important outcomes in people with CF. Common to other types of diabetes, people with CFRD are also at risk of developing what we call microvascular complications, meaning that risk of developing kidney disease or affecting vision or nerve damage. It is thought to be a little bit less common than compared to type 1 or type 2 diabetes, but is seen in people with CF as well. And in contrast to other types of diabetes, people with CFRD are thought to be at lower risk of conditions like heart attack or stroke, which are common complications in other forms of diabetes. One sort of evolving landscape or change that we don't know about is that how these highly effective modulators may impact the risk of these complications. We already are seeing that with these modulator therapies, the lung function and nutritional status is much, much improved, and it has significant beneficial impact on that. So we may see the relationship of CFRD with these unique CF-related complications may change. Similarly, we're seeing that with these modulators, the metabolic profile of people with CF is kind of becoming more and more quote-unquote normal looking. So meaning people may have, just as with general population, the risk of cholesterol being higher is increasing, rate of high blood pressure is increasing, and the risk of coronary artery disease and so forth may also change in the coming years. So here's just to highlight the changing nutritional landscape in CF. As you are well aware, traditionally, CF is associated with undernutrition. However, with advancement in overall care, a lot of emphasis on nutritional therapy, we have had a lot of success in improving the overall nutrition. And this table here shows, this is data from CF registry. On the y-axis, you see the BMI, and blue is men and red in women. As you can see, over the last 20 years, there's steady improvement in BMI. However, with this success, we've also seen increase in rate of overweight and obesity, which has started to look like what we see in general population. So here's data, just as you can see that in about 1/3 of adults with CF, their BMI is now in the overweight or obese category, which is starting to mirror what we see in general population. So what are the risks associated with overweight and obesity? In the general population, obesity is associated with increased risk of number of metabolic problems. For example, risk of type 2 diabetes, high blood pressure, heart disease, cholesterol abnormalities, fatty liver, and also increased risk of heart disease or stroke. So what are the relationship between nutrition and CF? Now, one important aspect of nutrition and CF is a strong association between nutritional status and lung function. So that's what you see in this figure here from CF registry, showing that low BMI is associated with poor lung function. And as the BMI improves, you can see there is a linear relationship that as the BMI is improving, nutritional status is improving, the lung function improves as well. However, once it comes to a certain point, the BMI in the higher overweight obese range, then this effect on lung functions really seems to flatten out. As you can see in this figure here, if you look at this sort of solid line, you can see the BMI. With the BMI, the lung function improves, and at around about BMI of 28 and 29, it sort of flattens out. So we don't know if there's really any benefit of continued improvement in lung function as the BMI goes into the obesity range. So we know little about what are the risk factors or potential complications of obesity in CF. What we know from limited studies is that people who have milder form of disease, who have less severe mutations, who are pancreatic sufficient, are at increased risk of excessive weight gain, and also CFTR modulator use, particularly the newer highly effective modulator, are associated with increase in overweight and obesity. However, we are seeing that even in people with severe mutation who are pancreatic insufficient, the rates in overweight and obesity have increased as well. So far, there's limited data to look at potential adverse effects of obesity in people with CF. We know that we are seeing increased rate of hypertension, increased rate, higher level of LDL cholesterol, which is one of the cholesterols that we want to keep down in terms of risk factors for heart disease, higher triglyceride level, and also fatty liver. So this table contrasts type 2 diabetes, which is the most common type of diabetes, to CFRD. So I'm calling this here the traditional CFRD or the classic CFRD that we previously that we have seen. The key difference between two of them is that in type 2 diabetes, there is some dysfunction in the iLet cell, or the cell that makes insulin. So body is not making adequate insulin, but also there's a strong component of insulin resistance, which means that the body is not able to utilize well. The insulin is not as effective when the insulin resistance is present. Whereas in classic CFRD, we see that there is underlying defect in insulin production, but there is the insulin resistance is not a major factor. So that's one of the key differences between these two processes. In type 2 diabetes is associated with increased risk of obesity, high blood pressure, cholesterol problems, and also increased risk of stroke and heart disease, whereas these complications are rare in classic CFRD. And traditionally, type 2 diabetes is treated with oral medications and also medications that really focus on weight loss interventions and effects, and also insulin is also utilized, whereas in classic CFRD, insulin is the recommended treatment. However, with the changing landscape, what we're seeing now is this emerging phenotype that people with CFRD are also developing this sort of metabolic syndrome type picture, where they're also developing, with underlying CFRD, also developing some type 2 diabetes features. So here we're seeing increased rate of obesity, increased rate of hypertension. We don't know how that will affect long terms in terms of macrovascular risk or risk of cardiovascular disease. And we don't know yet what is the best way to manage this particular phenotype. Do we need to start considering using some of the medications that are used for type 2 diabetes? So I guess one of the questions is that how should CFRD be treated in this era of highly effective modulator therapy? Now, there have been a number of guidelines that have been published in the past, and insulin replacement has been the standard. But now with the metabolic changes that we're seeing with highly effective modulator therapy and overall increase in survival, we may have to consider using other options as well. For example, in our clinic population, about 60% of people with CFRD here in our center have BMI which is either in the overweight and obese range. Very recently, the International Society of Pediatric and Adolescent Diabetes, the society published an updated guidelines on management of CFRD in children and adolescents, and they do highlight this point that they say that maybe in certain cases where people are newly diagnosed without severe hyperglycemia, maybe we could consider using an oral medication instead of insulin. Similarly, they also highlight that at certain centers, drugs like metformin or other type 2 medications are being used. However, we don't really have adequate information to recommend these medications at this time. And really what's important is that more research needs to be done to establish safety and efficacy of these therapies in CFRD. So when you talk about pharmaceutical management of CFRD, based on the current data, the guidelines recommend insulin as the only pharmaceutical therapy for management of CFRD. And this is based on years of data that we know that in insulin therapy in people with CF, it not only improves glucose control, it also improves nutritional status, promotes weight gain, stabilizes and improves lung function, and also associated with decreased frequency of pulmonary exacerbation. However, again, as we pointing out earlier, as with changing landscape of nutritional status and lung function with this highly effective modulator therapy, this impact may change, and there may be in select patients we could consider using alternate therapies. I want to just highlight for discussion a couple of therapies that are of interest in CFRD, which a number of groups are doing research on, and one of these therapies is called incretin-based therapy. These incretin hormones are hormones made by our gut, and they actually improve the insulin secretion by pancreas, and they also have a strong weight loss effect, which is mediated through its action potentially on the brain. And these medications are a very popular class of medication for type 2 diabetes and weight management. And there's interest in utilizing this in people with CFRD. However, there are side effects, potentially pancreatitis, gastroparesis, that may be of concern in CFRD. I'm just wanted to share some a case series that we have not published it yet, but we're in the process of doing that, just highlighting some early clinical experience of using one of these injectable medication. This is given once a week, and as you can see in this graph, these 4 individuals have used this for more than a year. This is it's been used along with insulin therapy and has led to significant improvement in A1C as well as reduction in weight loss. So far, one of the main concerns with this medication is gastrointestinal side effects, and in our limited experience, and people have tolerated it well. Again, but this is just a case series, so it doesn't really represent strong evidence. However, as a next step, we are in the process of doing a clinical trial to study the safety and efficacy of this class of drugs in a more systematic way in individuals, particularly who are overweight and obese with CFRD. Another class of medication that is of interest is called SGLT2 inhibitor. This is again a very commonly and popular drug in type 2 diabetes. It works by essentially making you excrete or lose glucose through urine, and it reduces the peak that happens after meals, and which is very commonly seen in CFRD. So this is sort of an attractive option for that. There's really no literature or studies in CFRD at this point. However, we are in the process of doing a clinical trial of this medication in CFRD, and I'm just sharing some limited clinical experience here in our few very selected patients who where we're using this medication along with insulin, and has led to improvement in glucose control, and has a sort of some weight loss effect as well, but without any significant side effects. So this is again a couple of medications who have potential of being beneficial in CFRD and have an alternative to insulin therapy in some select patients. However, I just want to highlight that this is really early, and we need more research and clinical trial data to support its use. So in summary, overnutrition is rapidly growing among people with CF, and which is starting to mirror the obesity epidemic in general population. The long-term impact of highly effective modulator therapy on glucose and other metabolic risk factors is not yet fully understood. And we are seeing this new phenotype of CF-related diabetes, which is associated with metabolic syndrome. And we don't have much data right now to support its optimal management. And it's possible that we need to study about potentially increased risk of cardiovascular disease in people with CFRD in the future. And we need to develop new pharmacological strategies for CFRD management in this setting of this changing nutritional landscape. Thank you so much for your attention.
Okay, guys, so we all love technology. In fact, we all love it so very much that we have a computer in our pocket, otherwise known as a cell phone, and I guarantee you all have one out right now. And some of us even get to carry around two of these lovely things because one is not a cell phone. So Dr. Melissa is going to tell us all about some of the awesome new technology that is on the forefront and how it can help to benefit those of us with CFRD and what we can do about it. So Dr. Melissa, let's hear some cool stuff.
Excellent. Thank you so much, Katie. Yes, so my name is Melissa Putman. I am an adult and pediatric endocrinologist in Boston. And my fun fact today is I have an identical twin sister, and my twin has twins, and I have twins too. So twins everywhere in our family. But all right, so what I'd like to do now, oops, slide, there we go. So for the next 20 minutes, I want to really quickly go over some of the diabetes technology use in the management of CFRD, focusing on continuous glucose monitors, smartpens, and hybrid closed-loop insulin pumps, which we'll go into more detail. And then I wanted to highlight some emerging technology, the Bionic Pancreas, and some exciting new results from studies on this. All right. So I think as many people on this call are aware, people with CF and CFRD face a lot of very unique challenges in managing diabetes. So one is just the added treatment burden of adding diabetes tasks, finger stick checks, insulin injections, carb counting, on top of everything else you already do to take care of your health. In addition, as many people have probably noticed, there's a really variable degree of insulin production from the pancreas, where some people with early CFRD may need just a little bit of insulin, but then other people may need a lot more insulin. And that insulin production can change even within a person. So if you're healthy, maybe, again, you need just a little bit of insulin, but then if you get sick, you need a lot more. And it can be a lot to keep up with all these changes in insulin requirement. In addition, many people with CF need to eat a high-calorie diet, which often entails high carbohydrate meals and snacks, which can lead to a lot of ups and downs in the blood sugars. In addition, people with CF, even without diabetes, even not on insulin, are at risk for spontaneous low blood sugars. And it can be hard to treat with insulin for someone who's already having a lot of low blood sugars. And then all of this really adds up and can have a big impact on quality of life. And diabetes technology is kind of geared at trying to help all of these challenges. So what do we know about diabetes technology in the CF community? The answer is not that much, actually. But this was a study that we published not too long ago that we worked with the CF Community Voice program and sent out a survey asking people about technology use. And in the people who responded, about half had CFRD. And of those, about 75% reported use of continuous glucose monitors, or CGM. And that's actually pretty high compared to what we see for people with type 1 diabetes. But about a third of people stopped using the device due to primarily excessive cost and loss of insurance coverage. And in this sample, 29% of people reported use of an insulin pump. But again, almost a third of people had stopped using a pump at some point. And so really, I think this study is important because it tells us that we have progress to make in terms of ensuring access to and sustained use of diabetes technology in our community. So I want to start by giving a little bit of background about continuous glucose or CGM systems. And so CGMs are basically devices. You have a sensor and there's a little filament that goes underneath the skin. It's very small, the size of 2 cat hairs. It goes underneath the skin and it measures the sugar levels continuously over time. And you can see here at the top, these are our common CGM systems, the Dexcom G6 and the Freestyle Libre 2, which are the ones you probably are most familiar with. And more recently, the new kids on the block that just came out are the Dexcom G7 and the Freestyle Libre 3, as you can see here. And these systems are, the sensors themselves are super small, the smallest sensors that we've ever had. They send information to a smartphone or a receiver. So you can see here continuously the blood sugar levels for both of these. They are very accurate as finger stick checks in many cases. They send real-time alarms. So if blood sugars go high or low, it'll send an alarm to let you know. The applicator for the newest systems are just one piece, very simple and straightforward. And both of them are approved for use with yet has started. It will eventually be used with insulin pumps. And so when we think about these new systems, I wanted to highlight some of the differences of these. And so the G7, the Dexcom G7 has 10 days of sensor wear. So you change the device every 10 days. And the Freestyle Libre 3 is 14 days, so a little bit longer. The Dexcom G7 gives glucose values every 5 minutes versus every 1 minute for the Libre 3. The G7 can be used with a compatible smartphone or an optional receiver. This was a big limitation with the Libre 3 because in the beginning, it was only compatible with a smartphone. But just recently, like a week or two ago, they announced that there is a separate receiver that's been approved for the Libre 3. This will be helpful in getting Medicare approval for this device. And so that's a very exciting recent development. The G7 there are certain substances that can interfere with the accuracy. For the G7, that's high-dose Tylenol or acetaminophen, more than 4 grams a day. For the Libre 3, high doses of vitamin C can affect the accuracy. And I wanted to just highlight again, right now, neither of these two devices can be used with insulin pumps integrated, with hybrid closed-loop insulin pumps. But hopefully at some point in the future, they both will be integrated. All right, I wanted to give an example of why I personally love CGM, because it just gives us so much information. This is an example of an ambulatory glucose profile. And so you can see that we're getting from midnight here to midnight here, we're getting 2 weeks of glucose data, blood sugar data, all on one screen, averaged out. And so we can see, well, what percentage of time does this person spend with high blood sugars or low blood sugars? What's the variability of the blood sugars? And really helpful in the management of CFRD, and especially from my perspective too. So what do we know about CGM in studies looking specifically at people with CF and CFRD? And again, the answer is not much, but this was a study where investigators collected 3 days worth of CGM data and then used that information to start insulin in people enrolled in the subject. And they found that when they did start insulin, this led to improvements in pulmonary function and weight after 3 months, with a lower rate of decline in pulmonary function over a year. And they also had those starting insulin had improved glucose control. But this is people who were not on insulin and started insulin. What about people who are already treated with insulin and are already, checking finger stick checks? does CGM impact glucose control for these people? And the answer is we don't actually know specifically in CFRD because there have been no randomized clinical trials in the CFRD population. There was a recent meta-analysis and systematic review that compared CGM with fingerstick glucose, and they found a 0.4% improvement in hemoglobin A1C, which is our measure of average glucose over 3 months, and if people used CGM for 6 weeks. Now, this is actually not far off from what we see in type 1 diabetes, where studies have shown on average a 0.5% improvement. But the effects of CGM on pulmonary and nutrition outcomes were conflicting, and the quality of studies was poor with strong potential for bias. And so we really need more data on this. All right, now I'd like to kind of switch gears a little bit and talk about other devices, such as an insulin smart pen. And the one that people are most familiar with is probably the Medtronic InPen. And so this device is a pen, as you can see here, that looks like a lot of different insulin pens. This one you don't throw away. But this pen, and it holds short-acting insulin, so it can hold Humalog, Novolog, or ultra-rapid-acting insulin, Fiasp or Liumjab. So what this does is it connects to an app on the smartphone, which is what you can see here. And the app can help you calculate insulin boluses, do corrections. It records all the insulin injections, as you can see here. And this is the shape of the insulin, so it can actually take into account how much insulin is on board. This integrates with CGM, and so you can actually see the CGM, the glucose data right here as well. And so I've had many patients who found this very helpful for tracking insulin usage and helping with calculations. I also wanted to just take a very quick detour because when I'm talking about injections, one thing that I personally have found in my practice has been helpful for many people is something called ultra-rapid acting insulin. Now, you may notice that sometimes, especially people who have early CFRD who don't need quite as much insulin, you can see this pattern. I'm showing you a CGM tracing right here. You can see this pattern where the blood sugar goes up and then it falls and you get low blood sugars. Then it goes up and then it crashes and you get a low blood sugar. Often for people who are taking insulin, the typical insulin like Humalog or Novolog, I can see this because it's a timing issue. And if you don't give that in Humalog or Novolog 15 minutes before eating, which is really hard to do, if you don't do that, then you can kind of mismatch and it can lead to low blood sugars like this. So in this situation, I have found ultra-rapid acting insulin to be very helpful. So this is the Fiasp and Liumjab. And it basically, if this is the regular rapid acting insulin in the brown, the yellow is the ultra rapid acting insulin. So basically it acts right away. You dose it right as you eat. And it acts the same amount of time, but you just get more action up front. And so it's something, if you're having this pattern with the low blood sugars, this is something to consider. All right, now I'm going to talk about insulin pumps. So an insulin pump is basically a device where there's patients have a cannula that goes underneath the skin and it delivers insulin continuously over time. And so it's just short-acting insulin, no long-acting insulin, and you can adjust it minute by minute. You can tell it to give insulin when you're eating or when your blood sugars are high, and it can make, in many ways, help you fine-tune insulin dosing. And this is what insulin pump looked like in the 1990s, which is basically like a huge computer. And you can see that over the years, we've had a lot of improvement in our technology. And now the most updated versions of insulin pumps are integrated with continuous glucose monitors. And the ones that are currently available are called hybrid closed loop devices. And so the devices that the way these work is that the continuous glucose monitor, the CGM, feeds the sugar information to the pump, and the pump has an algorithm on it that helps it decide how much insulin to give someone. So it's basically like modulating the insulin delivery in the background. It's hybrid because users still need to tell it when you're eating. You still need to tell it how many carbs you're eating. And if blood sugars are really high, you need to tell it to give you more insulin to bring them down. But again, it's modulating your insulin in the background. If blood sugars are going low, it can stop insulin delivery to help prevent low blood sugars. It can be very helpful. This is an example of the tandem t:slim X2 with Control-IQ, which has, it's a pump. Here's the pump, and it has tubing. The Medtronic 670, 770, and 780G, which was approved, I think like 2 days ago, the 780G was approved. So we're getting this hot off the press. But that's what this one looks like. So it has a separate CGM and a pump with tubing. And then this is the Omnipod 5, which came out not too long ago. This is the only tubeless version. Here's the, oops, sorry, that's my horrible phone. This is the only tubeless version, and connected with the CGM here. And so these devices have been approved for type 1 diabetes and have been shown to lower A1C to, which is the average glucose over 3 months, to improve the time people spend in the target glucose range, and all doing so with stable or reduced levels of low blood sugar. It does require accurate insulin settings. So I, as a provider, have to set into the pump what the settings should be. And it still requires a fair amount of input from users, including counting carbohydrates and entering those in when eating, and then also giving boluses of insulin to correct when blood sugars are high. What do we know about these devices in CFRD? So this was a study that actually Amir and I published together. We collected information on glucose control in people children and adults with CFRD who had switched from either injections or another form of pump to the t:slim X2 with Control-IQ. And what I'm showing you here is their average glucose value on the y-axis, and then the time of day, so midnight to midnight on the x-axis. This blue line shows average glucose before switching to Control-IQ, and the shaded blue is the variability. And you can see here the red line that there's been a reduction in that average blood sugar level over the course of the day and night, and less variability. So it really suggests that this could be a good option for people with CFRD. And now I want to talk with you about an exciting development called the iLet Bionic Pancreas. And this is a device that's not yet approved. It's an investigational device, but we are studying this in CFRD, and I have some exciting results to tell you about. So this device is different. It's a fully closed loop pump, so it does not need any settings. It requires someone's weight to start, and then it uses the CGM input to learn and adapt to each individual person and what their insulin needs are, including when those needs change. So, and for this one, there is no carbohydrate counting. Instead, you can do qualitative meal announcements where you say this is a typical meal, greater than typical, less than typical, and all correction dosing is automated, meaning that if the blood sugars are high, the device will correct it. Even if you want to give more insulin, you can't. The device does it automatically. And this device was recently studied in type 1 diabetes. And in this trial, which was just published in the New England Journal of Medicine, they looked at the device over 13 weeks in 219 children and adults with type 1 diabetes. And they found that the device was safe and effective, and it brought A1C down by 0.5%. And it improved average glucose, time in hyperglycemic ranges, and did not affect time in hypoglycemic ranges. And based on these results, the device is currently undergoing FDA review for approval in type 1 diabetes. And so we studied this device in people with CFRD, and I'm excited to tell you about these results. And so this was a random order, open label crossover design clinical trial. So what that means is we randomized people with CFRD either to start with the Bionic Pancreas for 2 weeks or to start with their usual diabetes care for 2 weeks. And then they switched to the other treatment for the other 2 weeks. And we enrolled 20 adults with CFRD treated with insulin. We used the device exactly the same as it's used in type 1 diabetes, and there were no limitations on work, diet, or exercise. And these are the results. So I'm showing you here percent time in target range between 70 and 180, which is kind of what we're aiming for in terms of getting people's glucose in their ideal range. And each of these lines represents a different person in the study. And the size of the circles represent how much low blood sugars they were having. So bigger circle, more hypoglycemia. And then the white shows their percent time in target range when they were doing usual diabetes care. And then the blue shows what happens with the bionic pancreas. And you can see here, the red line is the average for the cohort. There was significant improvement in this percent time in target range, bringing the average up to above 70, which is our goal. And there was no change in hypoglycemia, which remained low pretty much throughout the study. And so these were really exciting results. And based on these results, our next step are to go on and do a larger, longer, multi-center randomized clinical trial funded by the NIH and the CF Foundation. And we are currently in the planning stages for this study. Our preliminary plan is going to be to randomize people to either their usual diabetes care or the bionic pancreas for 13 weeks. And then after that 13 weeks, then everyone will use the bionic pancreas for another 13 weeks. And this study is going to really help us. The goal of this study is to get FDA approval for this device for the indication of CFRD to hopefully improve access to this device for patients with CF, because it can be very hard to get pumps covered for people who don't have type 1 diabetes. And so that's really exciting. And this is also going to give us a great opportunity to look and see other outcomes, how this device can affect quality and pulmonary function and weight and all these other outcomes too. So I'm very, very excited about this study. All right, so by conclusion, I hope I've convinced you that diabetes technology has rapidly advanced over the past several years. And so now we have continuous glucose monitors, we have insulin smart pens, automated insulin delivery devices that all hopefully will help to improve blood glucose control and reduce treatment burden. But we need more studies. And so I hope I've also gotten you excited about our upcoming trial. Stay tuned for the Bionic Pancreas trial, which hopefully will be coming to a center near you in the near future. All right. Thank you so much for your attention.
Thank you, Melissa. That was fantastic. So next, we're going to talk about what everybody wants to hear about is CFRD and Trikafta. There's so much about modulators, modulator therapy. So now that we've heard all about our technology, what can we learn about Trikafta? For me personally, within 24 hours of starting Trikafta, I watch my blood sugar and my need for basal insulin come down. Now, that doesn't happen for everyone, but Dr. Tanicia is going to tell us the impact and what we know about CFRD and modulators. So Dr. Tanicia, can you tell us what we need to know?
Sure. Thanks, Katie, for that lovely introduction. Before we get started, everyone had a wonderful fun fact. Again, my name is Tanicia Daley. I am from Atlanta. I'm affiliated with Children's Healthcare of Atlanta, and I'm a pediatric endocrinologist. And so you see three individuals on this page. If we start from the left at the bottom, that first picture is Jeff Bezos. And then if we go in a clockwise manner, that is Justice Ketanji Brown Jackson. And then if we go to about 3 o'clock on the clock, that is Surgeon General Vivek Murthy. And I have something in common with these three individuals. And we all went to the same high school. I'm sorry, I'm having difficulty advancing my slides. Okay. So moving on to my fun fact, from my fun fact. And just before we get started in modulator therapy, I think it's important to just talk about what really is happening when you have mutations in CFTR. So again, everybody on this call already knows that with abnormal CFTR, which encodes for that protein channel sits on the top or cell of the cell surface, abnormalities causes abnormal transport of chloride and bicarbonate through that channel. And the result is that you actually end up with a dehydrated airway surface liquid. And then you also get impaired mucociliary clearance. And for those of you who don't know, mucociliary clearance, that's the primary defense mechanism of the lung. And so that is impaired. There's also abnormal transport of bicarbonate or abnormal bicarbonate secretion. And bicarbonate is important for helping maintain that airway surface liquid. And it's also when it's decreased, you're really not as efficient in kind of fighting off bacteria. So when we look at the different classes of mutations, we can go from 1 through 6. For the purpose of this talk in discussing modulator therapy, we are only going to focus on the first 3. 4, 5, and 6, we tend to classify them not as severe mutations, and CF-related diabetes, or CFRD, tends to be associated with class 1, 2, and 3 mutations, which are typically more severe mutations. So class 1 mutations. Class 1 mutations have a problem with protein production. And so in order to make CFTR, there's a code that's there that our body processes and makes the protein. But individuals who have a class 1 mutation are unable to make CFTR because there's a problem in that code or a problem in that recipe that allows for CFTR production. About 5% of individuals who have cystic fibrosis would have a class 1 mutation. Class 2 mutation is by far a more common mutation. And class 2 mutations, what happens is you're able to make the protein, so your recipe is good, but you don't fold the protein the way that it's supposed to be folded. And we call this a problem with protein processing. And so you are unable to still get get CFTR up to that the surface. So then a class 3, and I should also say with class 2 mutations, our delta F508 mutation is the more common mutation, and that is typically in our class 2 mutations. So class 3 mutation, what ends up happening is you make the protein forms the right shape, it gets all the way to the cell surface, and then when it gets to the cell surface, the ion channel is closed. So it does not allow for opening of the channel and allow for the flow of chloride through that channel. And so these are gating defects. And so some of the very first work that we have on modulator therapy were really targeted to these class 3 mutations. And so we'll talk a little bit more about these gating defects that we see in class 3 mutations. About 5% of individuals who have cystic fibrosis have these class 3 mutations. So what do CFTR modulators do? Overall, when we think about the big picture, they really correct the malfunctioning protein that's made by that CFTR mutation. And so as we kind of discussed with those class 3 mutations, depending on class 1 through 3 mutations, depending on what type of mutation you have, that is what the modulator really targets and tries to address and fix. And so some of the trade names that we're familiar with, you're going to see highlighted in blue. And some of the more generic names that we use to describe the drugs are on the right side. So our first modulator that we're going to discuss is ivacaftor. And ivacaftor targets that class 3 mutation. So remember we talked about protein folds. Protein has the right shape. It gets all the way to the surface, but it's closed. So ivacaftor, it binds to the defect at the protein, at the cell surface, opens up the channel, and allows for chloride to move through the channel. And so that is ivacaftor, and that is what ivacaftor does. Our next modulator, and ivacaftor came out in 2012. Our next modulator came out in 2015, and that's lumacaftor and ivacaftor. So it actually has two different modulators that are being used to help to try to target the protein defects that are there. So we have the potentiator, which is the ivacaftor portion that we just described. But then now we added what we call a corrector, which is what lumacaftor does. And so if you recall, when I spoke about class 2 mutations, what happens is that the shape of the protein it's not formed well. And as a result, they can't move through the cell as smoothly as they need to. And what lumacaftor does as a corrector, it tries to help with transport of that CFTR protein, transporting it through the cell to the surface. And individuals who are eligible for lumacaftor and ivacaftor are individuals who are older than 1 and have 2 copies of that delta F508 mutation or a class 2 mutation. So Symdeko or tezacaftor and ivacaftor, same thing. They had the potentiator, the ivacaftor, that helps with the gating defect at the surface. And then this was a different corrector and not lumacaftor, but tezacaftor. And again, though the goal was to fix the flaws in that folding of the CFTR protein. So individuals who qualify 6 and older, 2 copies of delta F508 mutation, so a class 2 mutation, or there are about 154 different mutations that can also fit in. And if you have one of those, you can qualify for Symdeko or tezacaftor, ivacaftor. And so Trikafta, or ETI is what I'll refer to it going forward, actually improved upon what we saw with Orkambi and Symdeko. And instead of just having one corrector, it actually has 2 correctors. So it helps with that protein that is not folded correctly. And then we have still our ivacaftor, which seems to be our mainstay, who at the cell surface is allowing for that protein channel, that chloride channel to open and allow for chloride to flow through. And as recent as yesterday, this drug is now approved for individuals who are 2 and older who have cystic fibrosis and have at least 1 copy of a delta F508 mutation. So this is wonderful news if you are one of the individuals who fall into that category of being able to qualify for these medications because you have a class 3 mutation. So for example, a G51D, or if you have a class 2 mutation, so a delta F508 mutation. But there's still individuals who have cystic fibrosis that don't meet those qualifications. And so when we look at overall modulator therapy, about 92% of non-Hispanic white individuals with CF qualify for modulator therapy. About 69% of non-Hispanic Black individuals with CF qualify for modulator therapy. So a significant amount of individuals who are Black are not eligible because they don't have a mutation that would qualify. For Hispanics, that number goes up a bit to 75.6. And other races, about 80% of other races have a mutation that would allow them to qualify for modulator therapy. So there's still more work to be done to bring everyone into the fold of trying to have medications or therapies that really target these CFTR protein mutations. So I'm going to change a little bit from talking about modulator therapy and just really kind of talk about why individuals with cystic fibrosis are insulin insufficient. I think Dr. Amir kind of alluded to this a little bit earlier, but I'll just quickly review. So there are few reasons, and I think that it's important to remind everyone that there's not just one reason why someone develops CF-related diabetes. Sometimes you can have type 2 related changes. So for example, individuals who have a family history of type 2 diabetes can have a higher risk of having CF-related diabetes. We know that there's some type 2 diabetes related genes that have some crossover with CF-related diabetes. So there is some shared similarity between type 2 diabetes and CF-related diabetes. There is also some thought that there's structural loss of the cells that produce insulin, and this is what's contributing to the development of CF-related diabetes. And then there's whether there's a location issue. So talking about those a little bit more. So again, where they are, structural loss. We also call this collateral damage or bystander defect. And so what ends up happening is that as a result of damage to the exocrine pancreas and the ductal part of the pancreas, the cells that produce insulin also get damaged as well. And so there's overall loss of islet cell architecture or islet cell mass, and that results in CF-related diabetes. The problem with this theory is that when we've done post-mortem studies and looked at individuals who have CF-related diabetes and those who don't, you can see that not all the time that correlates with CF-related diabetes in terms of remaining islet cell architecture. For example, someone with CFRD may have 50% of islet cells remaining, and someone who doesn't have CFRD may have 50% of islet cells remaining. So we know that loss of islets is not the entire explanation as to why someone would develop CF-related diabetes. So whether CFTR is involved in the islet cells themselves, again, those are the cells that produce insulin, remains to be very controversial. There have been studies that have shown that there is protein expression of CFTR in the cells that produce insulin, but some groups have said that we did the experiments and we did not see CFTR in these islets. If present, many of us believe they're probably in low expression and maybe not present in all of the beta cells. Another theory is, you know what? These islet cells, they're just in the bad neighborhood. They're just in the wrong location. And so islet cells tend to be very close to the ductal cells. And those are what get damaged when you have problems with the exocrine pancreas, why we have to take our enzymes. And as a result of that, there's some thought that the CFTR from the ductal epithelium contributes to the islet cell dysfunction. And these are mechanisms that we call paracrine mechanisms. And it's just a way of the cells communicating with each other. And one cell is providing a signal to nearby cells that may alter the behavior of those cells. The exact mechanism isn't really known, and this is at this point more so theoretical, but it is we're thinking that there may be some kind of proxy relationship between the exocrine pancreas and the endocrine pancreas. So when does beta cell dysfunction really begin? You've heard many of people say, as you get older, your risk for developing CF-related diabetes increases. But I want to go ahead and make sure that we discuss that these glucose abnormalities can start actually very early, within the first decade of life. And so this was a study that was done that looked at individuals with CF from 3 months to 6 years. And about 39% of them had abnormal glucose metabolism. So insulin secretion did not increase with age, And so this really suggests that CF related diabetes pathology can start very early. This was another study that looked at individuals with CF ages 6 and up, between 6 to 9 years, and followed them over time. And what they found was at a 5-year follow-up, those who had abnormal glucose tolerance had an 11 times greater odd of developing diabetes compared to those who had normal glucose tolerance. And 10 years after the initial study, 42% of the children with abnormal glucose tolerance ended up developing diabetes compared to 3% of individuals with normal glucose tolerance. And so those who had abnormal glucose tolerance at a much younger age tended to go on to develop CF-related diabetes on average at 11 for girls and 12 for boys, compared to 23 for the general population. So this is the part that everybody is waiting for. How does modulator therapy impact glucose metabolism? So this very first study was relating to looking at CFTR and how CFTR was involved with insulin secretion. And it was really targeting that first drug that we mentioned, ivacaftor. And so this study enrolled 5 patients with cystic fibrosis. The first patient was a 52-year-old female who had diabetes for several years. The second patient actually did not have diabetes did not have a diagnosis of diabetes prior to the onset of the study, but went on to develop was diagnosed with CFRD at the beginning of the study. Patient 3 and 4 had normal glucose tolerance, and patient 4 was 6 years old, and patient 5 had abnormal glucose tolerance. So patient 5 was the only one in the study. What they did was they did oral glucose tolerance test at baseline and then 1 month following ivacaftor. Patient 5 was the only one that changed glucose categories in the study. Went from impaired glucose tolerance or prediabetes to normal glucose tolerance. Everyone else had no change in their glycemic category. They all stayed either CF-related diabetes or normal glucose tolerance. What this study really did was looked at insulin secretion. And it's notable that when we did an oral glucose load and looked at insulin secretion, everyone had improvement in their insulin secretion except for patient 1 who had long-standing CF-related diabetes. The other thing that they looked at was how quickly someone produces insulin with a glucose load. And patient 1 and 5 had the biggest change. And patient 2 was the only one that actually had a decrease in that acute phase insulin response. And when the authors kind of, came to the conclusion of their study, they really thought that this was the first to suggest that CFTR may actually be involved in insulin secretion, and it was rather promising. The second study that we looked at was a study that was done by Dr. Moheet. So you heard from him first. And this was looking to see if lumacaftor, ivacaftor, which was released in 2015, if it had any improvement on insulin secretion. And so oral glucose tolerance tests were done at baseline, 3 months, 6 months, and 12 months. And 39 subjects were enrolled in the study from 16 different centers. The age range was 12 years old to 51 years old. 30 subjects completed the full 12 months of the study. And significant findings from the study, they were able to see a decrease in sweat chloride and an increase in the BMI in adults. The BMI in children was unchanged, and FEV1 was really unchanged. But more importantly, when you looked at glucose categories, majority of the individuals stayed in the same oral glucose tolerance category that they had been in. Some of them, a minority, 15%, worsened, and 23% of them improved. But then when we look at glucose distribution in that top figure, we can see that Orkambi did not have an impact on glucose level. And then when we look at this bottom figure, figure 2, looking at insulin levels, that there wasn't that much improvement in insulin levels throughout from baseline to 12 months. And that time to insulin peak was unchanged as well. And so what the conclusions with this was that insulin secretion really didn't improve and glucose tolerance did not improve with Orkambi. The last slide that I'm going to show you, the last study was done by Dr. Putman and her group. And the goal of the study was to try to capture glycemic changes over time with the CGM. Because we're running a little bit low on time, I'm going to fast forward to the findings. And so what they did was they got glycemic measures with CGM before individuals started ETI, so the Trikafta. And then they looked at the changes in those glycemic measures after being on Trikafta. And that could have ranged anywhere from, initially it was supposed to be a 3-month follow-up, but because of COVID, things got delayed. And so that was anywhere from 3 months to 12 months. And so when they looked at the CGM findings, there was some improvement in the absolute changes in average glucose, the standard deviation of the glucose, and the peak glucose. There were no significant changes, unfortunately, in our measures for low blood sugars. There was no significant change in BMI weight or modified activity questionnaire. And so some of the findings from this study were that with ETI or Trikafta, there could be some improvement in CGM-derived measures of glucose that look at hyperglycemia, but there were no measures in terms of hypoglycemia or low blood sugars. And I'm sorry, there are 2 more slides that I have that I really quickly want to go through. And that was the more recent that those looked at glycemic measures by CGM. This was PROMISE study, and this looked at insulin secretion and glucose glycemic tolerance. And at the end of the day, there was no significant change with Trikafta with these parameters. And then one thing, there is some literature that may suggest that high blood sugars can impact the way our highly effective modulator therapy works. So there's more to come with that. And so at the end of the day, I'm going to say that ivacaftor showed some improvement in insulin secretion. Still unclear what's going on with Trikafta. We still need further research as to whether CFTR, what the role is in beta cell function, because that I think will help us to understand if we can improve insulin secretion and glucose tolerance. And then there's still some knowledge gaps in the role of high blood sugars and its impact on how highly effective modulator therapies work. And I apologize for going over.
Thank you so much, everybody, for your presentations. We are just about out of time for tonight, but I'd like to thank all of our speakers, Dr. Amir, Dr. Melissa, and Dr. Tanicia for sharing with us tonight. We do have time for just one question, but I would like to invite you all to the round table with Dr. Melissa and to myself, where all of your questions have been gathered, and we are going to make sure that you get those answered. So please come over and join Dr. Melissa and I to answer those questions. But we have one question specifically for Dr. Amir that you need to answer before we go tonight. So Dr. Amir, the question was, are there any studies underway to get more quantitative information about the prevalence of micro and macro vascular complications in patients with CFRD using modulator therapy?
Well, thank you. That's a great question. The data about microvascular complications the best data was several years ago. So it was, a pre highly effective modulator therapy. So we really don't have any published good data since in the contemporary sort of situation. But I know that there are investigators who are planning such a study, and it takes several years to sort of start seeing the impact of these therapies on because these complications take some time to develop. So I think we will learn about them in the coming years. And there's to answer your question, I'm aware of this one study that is being developed to study this question, but hopefully that we will see data from that in the coming years.
Great. Okay, thank you. Before we go for tonight, I'd like to ask each of our attendees tonight that you please take some time to fill out the satisfaction question under the poll tab on the right-hand side of your screen, right next to your session chat. We'd love to know how you feel about today's conversation. There are many wonderful resources related to this discussion, including the slides from today in the resource document found on the reception page. Please spend some time exploring those resources and download anything that you feel that you want to keep. Next up is the break and the roundtable with Dr. Melissa and I. So please make sure you come and join us. Or if you need the 30-minute break, you can take that too. But our closing keynote starts at 8:15 p.m. So please continue to join us tonight. There are other roundtables and other discussions for you to enjoy tonight as well, so you can get your questions answered. The staff will be here and can answer questions that you might have as well for information on foundation-sponsored research projects and initiatives, including wellness resources that are available to the community at large. All of the attendees are encouraged to jump on, to share your screen, let us see your faces, interact with us, and turn on your mic, turn on your video, and make sure you come again. Join Dr. Melissa and I over in the CFRD management tonight, and we will see you soon. Thank you so much for attending. Bye, everybody.